So my name is Katie Clerkin and I'm a clinical specialist radiation therapist in the Beacon. So the presentation today will discuss a recent audit carried out in the hospital comparing breast treatments using our old technique, the Varian RPM, with SGRT Tattooless using the AlignRT being our new technique. So first of all, just to recap a little bit on SGRT in the Beacon to date. So we have the two treatment units, the Trilogy using the AlignRT, and we have the Varian Edge using the OSMS. So to date in the Beacon, we treat SGRT cranial, extremities, thorax, abdomen, pelvis, and the breast, chest wall, and superclav. So my colleague Marie Coffey earlier would have talked in more detail on all those other sites, and I'm just going to focus on the breast, obviously. So we did our first free breathing breast Tattooless back in February of 2018, and then we did our first DIBH Tattooless breast in January of this year, 2019. So we obviously have the AlignRT system on the Trilogy unit from back in 2014, where we started first with the cranial SRS treatments, but it is obviously a huge shift to go to the breast treatments. So just a little bit of background then on the Varian RPM system. So we've had that since 2007, so we've used that for a long time now, and we obviously have a lot of experience with that. The RPM system itself uses the reflective infrared marker block, as you can see there, which is positioned with tape on the patient's abdomen. And this block is positioned in the same place each day as per a reference CT tattoo mark. The block acts as a surrogate for DIBH lung filling and measures the respiratory pattern and range of motion and displays them in a waveform, which you can see there as well. So SGRT for the DIBH breasts. So just to recap, as we all know, the SGRT is a rapidly growing technique which uses stereo vision technology to track the patient's surface in 3D for both setup and motion management during radiotherapy treatment. So just to highlight, first of all, I know we've spoke about this earlier in the day, the importance of the ROI, but here you have the three different ROIs. So say, first of all, you've the breast isocenter ROI, and then the one in the middle is a centroid arm ROI, which we use routinely in the Beacon. And then the third one you have there is just an example of a chest wall superclav ROI, where we've obviously made the ROI a little bit bigger to include the superclav region. So I can't really stress enough the importance of the ROI itself and everybody drawing the same ROI and having your staff up to date on training competency in that. So again, we've discussed earlier today the workflow of setting up the DIBH breast, so I won't go into huge detail again on that, but to recap quickly, it's pretty straightforward. Our free breathing DICOM reference to begin with, and then we always switch to our arm ROI, the importance of that being that we can then adjust for any pitch or roll with the arm, and then you can easily switch back to your breast ROI. If you're happy with that, then you go straight to your DIBH ROI. Obviously, you're going to practice in the room at least twice that the patient can consistently reach the amplitude for the breath hold. The audit that we did, so just to cap why bother doing the audit, so a comprehensive audit of a radiotherapy program reviews and evaluates the quality of all elements involved in radiation therapy, including staff, equipment and procedures, patient protection and safety, and overall performance of the radiotherapy department, as well as its interaction with external service providers. So first of all, we thought, best, obviously, as we've discussed earlier as well, the main reasons for getting rid of tattoos in general, and all the positive things that come from that. So the second main thing for doing the audit was to basically get all our staff on board, so to get the whole department confident that this new technique is going to be as good as, if not better than, the old technique that we're using. So the whole staff being our consultants, our physicists, and all our RTs. So the talk that we actually had yesterday evening here before the workshop went into, implementing change in a department, and it was interesting that it is so important to get all staff on board from the get-go, from the very beginning. So we did, similar to Inverness, a site visit in Nottingham, and when we came back from that, we did a presentation for the whole department to show everybody exactly what we learned from that visit, and how straightforward and easy it was going to be to implement that. So that was a good starting point. Another good thing that I thought that we did was we got all our staff in the department to basically wear a white skin-tight t-shirt and get physically on the bed themselves and practice doing the setup for DIBH. So it meant that every RT was either on the bed, practicing the breath hold exercises themselves, realising what it's like to lie in that position with your arms up with 3 cameras and a red light in your face and the real-time coach over your head as well. And it gave everybody the opportunity to practice setting up in the room and using all the tools of the system. So I think that was a good practice run for everybody in general, and to get everybody on board with making this change in the department. So implementing AlignRT, what changed for us? Our mobilisation stayed the same. So as you can see there, for all our 2-field breasts, we use the OIS supine breastboard. For all our 3-field breasts, then we add an arm shuttle to that, and we also make a VAP bag for all of those patients as well. The importance of the VAP bag being, obviously it's more comfortable for some patients who struggle to hold their arms up, and as well as that, for the 3 fields that you have exact precision for the mobilisation of the supraclav area. So that stayed the same, we didn't change that procedure. The only thing that did change, obviously, is from using the Varian RPM to the AlignRT 3D. So our old system, the Varian RPM, as I was talking about, uses, let's just discuss that earlier, but the AlignRT, which has the 3D stereo camera units to track the skin surface to select optimum tracking points on the patient's surface, ensuring the efficient and accurate gating. So the audit that we did, we looked back on our old system of the Varian RPM, and we just chose randomly 10 patients, 10 DIBH 2-field patients. And then we looked at our first 10 patients that we treated with the AlignRT. So obviously the Varian RPM system, we've 10 years experience doing that, so it was very easy to pick 10 random patients from that cohort. The AlignRT, it was going to be the first 10 patients that we had actually treated. So for each, the RPM cohort, 15 to 25 fractions was the patient scheduling, the AlignRT, 15 to 33 fractions. So RPM, the total fractions were 179, the AlignRT, 206 fractions. So they're pretty comparable, the two groups. So the variables then that we looked at for everything was the magnitude of the shifts, the time taken for the treatment itself and the total time, the number of images that we were taking, and the number of reset-ups in the room. So we'll start first with the three graphs that you're looking at here show the frequency of the magnitude of the shifts in all 3 directions. So your vertical, your longitudinal, and your lateral. So the first one, we can basically show there the 3 that you have, but looking at the vert, long, and the lat, our blue line there is our old system of the RPM, our orange is our new AlignRT. So you can see straight away that you have a lovely peak on your orange and that we're closer to the 0 mark. So that says straight away that our shifts are a lot smaller with using AlignRT in comparison to using RPM. So that is always a good thing. So it just means that it's a more reliable setup with intrafraction monitoring. So it makes us think, can we move away from daily imaging? Like at the moment, our standard procedure is daily imaging for all our patients, but it's just a little bit of food for thought in that, do we need to daily image these patients all the time when we have such small shifts and such a reliable system? So looking at the total average times, you can see there they're pretty similar, or again in orange that the AlignRT is slightly less time, slightly quicker. So on average, the old RPM patients were taking 14 to 18 minutes. The new technique, the AlignRT, was taking 12 to 18 minutes. So just to highlight here from this average time, you know, we were looking at the first 10 DIBH patients that we had treated. So obviously it was a new technique and staff are still getting familiar with it. But it is good to know that there isn't a huge difference in the time there, considering the old technique was something we'd done for 10 years that we were obviously very familiar with. And again, to highlight, out of the first 10 DIBH patients that we looked at, patient number 2 there was particularly anxious. So that's probably the reason why she took a little bit longer. So that's a good thing. And then looking at the number of images, again, for this one, we can say that it is pretty comparable for both. You could say for the SGRT group that we may have done more resetups or number of imaging. And again, I think that does come down to the fact that it was the first 10 patients that we were treating. So I think which we will do is repeat this audit next January 2020, a year later. And I think from that, the results that we would get would be, again, smaller shifts, but I think we would see a huge difference in the length of time it's taking us to treat these patients and the number of times of maybe resetting up some of these patients, similar to what, again, Inverness had said that they've noticed it is a lot quicker. And just going from that, after looking quickly at the 2-field breasts, we said we would have a quick look at our 3-field dual ISO breasts. So we're obviously treating those as well, Tattooless in the department. So we quickly took a look at the first 5 3-field DIBH Tattooless breasts that we had done, and again randomly chose 5 from our previous system, our old technique of the RPM. So looking at this was a little bit more positive, I thought, because it means that they're pretty comparable. We're doing as much imaging and resetups as we were before, which is very little. So I think that it came from the experience as well of doing more of the 2-field breasts, and then flowing into the 3-field breasts was pretty straightforward. So again, we'll repeat this audit, I think, next year, just out of interest to see the exact difference in the magnitude of shifts that we're getting for these patients and the length of time that it's taken us to treat the 3-field breasts. And obviously you have to think that the 3-field breasts are always going to be more difficult than the 2-field breasts to treat. The superclav is always going to be more difficult to get perfectly into position. So advantages of AlignRT. We've noticed a lot of advantages of the AlignRT, to be honest. And first of all, the arm ROI, I think, is a good one. I don't know if every centre is using that, but I think it is a good tool to use. That it just means, especially for your 3-field breasts, that you can easily switch from your isocentre breast ROI up to an arm ROI, and it just gives you a little bit more information about, is your arm in the correct position? Is the patient slightly pitched or rolled in any way? So I think it is important to use your arm ROI. And again, as treatment goes on, if patients have had surgery and they're doing more of their physio exercises, their mobility in their arm may change. So that may affect how they're holding their arm in a VAP bag or not as well. They may be more flexible now than they were at the time of CT. As well as that, some of our patients are quite nervous when they arrive to CT. So naturally, they're going to relax a bit more when on treatment. So again, that means that their position in general can change slightly. So the arm ROI we have found to be very helpful. And I know it was discussed earlier, the treatment capture. For us, we take the treatment capture every day, so we're using that routinely at the moment. And again, it's very handy for patients who are either arching themselves or holding themselves very differently on the bed. So you take the treatment capture and it easily gives you arrows to tell you where the patient needs to be changed to, into what position. And going back to the upgrade that we'll hopefully get next year, the VisionRT 6.2. So from that, the video function as well will be a very helpful tool in that it basically shows you exactly where the patient needs to be moved to. So I think that'll be very handy for us. But for the moment, the treatment capture works very well. And I know, as discussed earlier by other people, the surface stats. So if you've bothered to take a treatment capture, you might as well use your surface stats to have a look at what percentage that's giving you. And as well as that, we always record our SSDs using the treatment capture. At the moment, you have to manually put in your gantry angle and your collimator rotation. But again, with the upgrade, the treatment capture option automatically gives you the SSD for every field that you're going to treat. So it saves a little bit of time that you don't need to manually put in a gantry and a collimator angle. So again, it's just another handy tool. And going forward from that as well, with the surface stats one, I know a talk earlier discussed the seromas and how handy it is to have your surface stats if you have seroma. But for us as well, we noticed that any breast swelling, any edema, anything like that, your surface stat tool is very handy to actually measure what change is there and what you're going to do about it. Bolus, so this is an example of a 3-field bolus patient that we had. And again, I know people have asked questions earlier in the day about how difficult or not the bolus is. We didn't find it difficult at all, I think, because we had a few with a few three-field breasts anyway that we were familiar with doing, so adding bolus to this chest wall wasn't going to be much difference. I know VisionRT recommend to use paper towel over the bolus. That didn't work for us, I think, because of the gantry moving around. The paper towel was nearly blowing off the bolus and you're still getting the shine and the noise in the cameras. So we actually just used tape. We used tape on the bolus and used the same micropore tape on the bolus each day for this particular patient, and that left no shine or no noise from the cameras. So that worked pretty well for us. And again, I'm not going to go through the workflow of the 3-field, but if there is anybody that wants to go through in detail, setting up the 3 fields and then the additional bolus as well, you can come and find me after this. But it is pretty straightforward. We had no problems with that. Another example I can give, just of things that can change on set, was one 3-field patient that obviously was very nervous in CT, and by the time that she got to the treatment unit, her clavicle position had changed, not hugely, but changed a little bit. So we did notice that 2-3 consistent days of the clavicle, the image was acceptable but not perfect. So I know from listening to some of the talks earlier, it was kind of going straight to a replan, but I think from this system, it's very easy to take a cone beam. We don't routinely take a cone beam CT on our 3-field breasts. We do KV imaging on the superclav and MVs and the tangents, but in that particular case, we just did a cone beam on this patient. Our physics team did a dose calc, and we're able to decide from that, are we still happy with the coverage of the superclav nodes? If we are, yes, that's perfect, then we don't need to rescan this patient and do a new plan. But also what we can do, usually we would set up to the CT DICOM, but in that instance, this patient was more consistently setting up to her day 1 of treatment, so you can approve a treatment capture and you can set up to her day 1 of treatment rather than setting up to her CT. So that was just an example of how that worked. Pretty good for us. Conclusions to end then, the SGRT is now used routinely as standard in our department for all the 2-field, free breathing and DIBH patients, along with all the 3-field dual ISO, free breathing and DIBH patients. The SGRT has proven to be a more reliable setup and improved our safety standards with real-time intrafraction monitoring. The SGRT has demonstrated an improvement in accuracy as noted from the audit and the reduction in the magnitude of shifts required from imaging. So we note that SGRT is as good, if not better, than the RPM system that we used to use. And again, this highlights the fact that do we need to image these patients every day? And overall, the introduction of SGRT for breast patients has been positive in our department. All staff are fully trained and competent in its use, and they're happy with this new technique, and SGRT is user-friendly and, from what we thought, is very easy to implement. So that's it. So thank you to all. We can start.